Good afternoon, good morning, I don't know, good evening. Maybe someone will look through the lecture late night. I'm happy to introduce our speaker, Dr. Olga Kozareva. She is an MD oncologist from Dana-Farber Cancer Institute from Boston, the USA. And I'm very happy that she agreed to deliver the lecture on palliative care for our students and for our oncologists. Please, Olga, we are very happy. We are welcoming you.
Good afternoon. Welcome everyone to my lecture, and thank you for joining. Thank you for kind introduction. So today we will focus on symptoms management. So we have lecture on pain management because pain management is one of the common symptoms in any diseases, including cancer. Of course, my symptoms management lecture would be focusing on symptoms management in cancer population, but it can be applied to any patient population. I would like to be interactive. If you have questions, please text me and message me this question. And I have several cases, and it would be great if you able to participate. It's multiple choice. So let's start. So today we will talk about anxiety, dyspnea or shortness of breath, nausea, vomiting, diarrhea, constipation, bowel obstruction, anorexia, delirium. And I put a couple slides on pruritus or itchiness and hiccups, how to manage, because all of them can be very disturbing and pretty common. So I will start with alphabetic order. I will start with anxiety. So anxiety is pretty common. It's common in general population. It's common in patients with serious diseases, in especially such a life-threatening disease like cancer. And I always explain patients that cancer is very emotionally charged diagnosis. Even if patients have early stage disease, its reaction to this diagnosis very different compared to new diagnosis of diabetes or elevated blood pressure or elevated cholesterol. I also think that if patient has pre-existing anxiety, they coping. Can you hear me?
Yes, we can hear you. Should we start the presentation or not?
Oh, I'm so sorry. I already started. I'm so sorry. Oh, maybe I didn't. Okay.
Yeah, you have to share the screen.
Can you hear my screen?
Yes, yes, yeah, we can see.
So I usually explain patient, and if they have pre-existing anxiety that with cancer diagnosis or with any stress, their coping capacity is limited, and really it can be overwhelming with stress of cancer diagnosis. So and you need to explain patient that's normal to have some anxiety, and you also can go over some factors that can exacerbate anxiety, including pain. And we mentioned that poorly treated or undertreated pain, one of the cause of anxiety, and really can escalate fears and anxiety. Dyspnea or shortness of breath, it should be evaluated and treated properly. It also can decrease anxiety because frequently a patient who is suffering from shortness of breath, and this shortness of breath can be from chronic obstructive lung disorder, or it can be from lung cancer, congestive heart failure. It's can trigger anxiety, and anxiety will trigger more shortness of breath. So some medication can cause anxiety. For example, our famous medication we love and we use all the time called steroids, prednisone, dexamethasone. Some people tolerating totally fine, and some people can be very, very anxious. I noticed that medication withdrawal, especially if patient was on SSRI or for depression or anxiety and suddenly not able to swallow because they have bowel obstructions, they have painful mouth ulcer, and you stop this medication or suddenly this medication not available, they can have significant anxiety secondary to discontinuation of previously chronically administered medication for anxiety, depression. So some paraneoplastic syndromes, such as carcinoid syndrome, can cause anxiety. So substance use, we know it can cause anxiety. For example, cocaine or methamphetamine can cause significant anxiety. So an existential distress. That's it's a separate topic by itself. When person is dying, emotionally, it's very difficult. It can be patient can be grieving for the patient, be very sad and anxious what happened to his family and children after he or she passed. So how we manage anxiety? Of course, it's very important to establish the cause. A lot of time it's multiple causes, right? Psychotherapy and distraction is can work, and I can tell when we see patient in a clinic who is anxious, who is starting new chemotherapy, for example, we have for them a coloring book. We give them some coloring book and crayons, and they concentrating on making some drawing rather than look around and see what type of medication and nurses, how we running around, and they concentrating on something else. Even distraction with simple conversation about something not related to their condition can help. Psychotherapy absolutely can help with anxiety, and there is a several type of psychotherapy specifically focusing on anxiety. So we know pharmacological medications that can cause anxiety. One of the famous classes, benzodiazepines. They available in every country. They have short acting, ultra short acting, and long acting. Relanium, Millennium, lorazepam, Ativan, it's common. They work through GABA receptors. So we should be careful in elderly patient because some of the elderly patient can have paradoxical reaction to this medication. They can get more agitated. So if patient have pre-procedure or pre-chemotherapy, pre-biopsy, CAT scan, MRI, MRT related anxiety, we can pre-medicate them upfront rather than make them miserable during procedure. Because if you have anxious patient, it's difficult for us to manage medical problem plus address emotional part of this. So last week I had a patient who husband died from leukemia several years ago, and she was constantly with him even during bone marrow biopsy, holding his hand, and she was diagnosed with bone marrow disorder, and we decided to do bone marrow biopsy under conscious sedation because for her it's basically trigger PTSD, and it was very comfortable procedure for her. It also was very comfortable procedure for us who did bone marrow biopsy. And so very important medication to manage anxiety, especially if it's associated with dyspnea or shortness of breath, it's opiates, right? Because opiates decrease respiratory rate. It's can give relaxation, and opiates, Landau and tincture of opium, and with different other constituent was used for many years in the last and previous century for anxiety and relaxation. So Neurontin, gabapentin, I know there's medication available in Ukraine and in many other countries. Small dose, it's excellent for anxiety, very well tolerated in elderly patient. So, and safe, and small dose can be from 100 to 300 milligram. So SSRI, also famous class of medication, many of them exist. They have a different duration of action. So sertraline, fluoxetine, citalopram, paroxetine can be done, and if it's just anxiety, not depression, small doses pretty well tolerated, and you can see the difference. Bupropion, one of unusual and well tolerated medication, except seizures is contraindicated, helpful and acting faster than any SSRI. So interesting enough, we use a lot of antipsychotics. I know in the past, we used Haldol, a lot small dose. Now we have atypical antipsychotic called olanzapine. I don't know if it's available in Ukraine, but it's a good medication, safe. It exists in liquid form, can be given under the tongue. It's great medication for anxiety. It's great medication for nausea, and it's also increase appetite and increase weight. And so hydroxyzine or Atarax or Vistaril, good medication, is close to Dimedrol or Benadryl, great for PTSD, safe, no addictive potential compared to benzodiazepines, and also good for people who has itchiness for whatever reason. Or allergic reaction, it also can help. So medical cannabis, usually combination THC and CBD, 1-to-1 ratio or more CBD rather than THC, because in some patient purely THC, which is the active component of medical cannabis, can give anxiety and paranoia. I usually ask my patient if they ever had any experience with recreational marijuana before I start medication. But CBD is very safe, and it's easy to titrate, good for anxiety and good before bedtime. And so existential distress related anxiety, emotional support, spiritual care. Every hospital here, we have a priest. We have a priest of different religions, and we can ask for rabbi, we can ask for Buddhist priest if there is a request. So dignity therapy, this is a special therapy, I believe I mentioned in a previous lecture. Patient can write letter to daughter wedding or birthday, even in advance, with understanding that he or she will pass, and the letter will go to the family. Very helpful, improve quality of life, decrease anxiety. So the next, we will talk about nausea and vomiting. So nausea, vomiting related to chemotherapy, we usually follow protocol. It would be not addressed here in detail because every chemotherapy drug have a nausea, vomiting potential and managed very specific way with premedication and post-chemotherapy prevention. So I just would like to go over some cause of nausea and vomiting. Anxiety can definitely cause nausea and vomiting, especially when patient come prior to procedure extremely anxious, maybe driving from far away. A lot of time we call this anticipatory nausea, sometimes vomiting when patient anticipates that procedure happen, and they start anxious, and sometimes it can be in such a degree that they start having nausea and vomiting. So pre-medicate patient and do prevention in advance, usually with benzodiazepines. So hypercalcemia definitely in any electrolytes abnormality. Two main electrolytes is calcium and sodium can give nausea and vomiting. So you start treating hypercalcemia with hydration, with Zameta, with Lasix, calcitonin, and treatment of disease if possible. But checking electrolytes and addressing this very important. So the hydration, frequent cause of nausea, and hydration can fix it. We know if even patient has stomach bugs, some viral gastroenteritis, if they're getting dehydrated, nausea is pretty common. So simple gastritis can give nausea and vomiting. And again, we should evaluate the cause, because gastritis is definitely different from hypercalcemia in terms how we manage, right? And gastritis can be managed with PPI, Malaox, or H2 blockers, and treated H. pylori if needed. So constipation can cause nausea and vomiting. If it's a severe constipation, patient have increased pressure intra-abdominal, definitely it can cause nausea and vomiting. Frequently, if it's combined with ascites, there is no space in the abdomen, patient can have pretty severe nausea and vomiting. So medication and chemotherapy, we always review medication to make sure there is nothing patient taking. For example, patient has gastritis and low potassium, don't give them oral potassium replacement because it irritates the stomach and will make nausea, vomiting, and gastritis worse. So brain metastasis, patient have persistent nausea, vomiting, maybe associated or maybe not associated with neurological symptoms or mental status change. So rule out brain metastasis, nausea, vomiting persist, or patient have malignancy with high CNS metastatic potential. So bowel obstruction, you probably all know, pretty common complication, not only in oncology patient, but in general patient population, can be related. Cancer can be related to ileus, paresis, can be related to malignant bowel obstruction. So nausea and vomiting pretty common. Of course, you need to treat obstruction, can be surgical management and can be therapeutic management. So, and as I mentioned, frequently nausea and vomiting can caused by several factors. So now we will talk about vomiting. Again, establish a cause, treat cause if possible, right? And all medication should be IV or sublingual, right? If sublingual medication not available, it should be giving IV. Zofran and ondansetron, pretty common medication. I know in Ukraine you use widely, and Zofran sublingual tablets exist. So dexamethasone also available. Can be giving IV. Sublingual, it's not well absorbed in oral mucosa, but well absorbed through PO, but in case of vomiting, it's not relevant. Ativan can be giving IV, Compazine, Prochlorperazine can be giving IV, and Haldol can be giving IV, small dose, safe. Of course, we always make sure that patient not get more than 1 gram without 1 milligram without AKG, because it can increase QT interval. So another tip, if patient we anticipate nausea, possible vomiting during chemotherapy, we recommend ginger tea. Or ginger in capsules. It's actually clinical trial was done. It's decrease chemotherapy-induced nausea and vomiting when it's given with standard chemotherapy pre-medication. So medical cannabis can be pretty useful in nausea, but not in vomiting, although oil formulation exists and can be given under the tongue. And some people, some of patients prefer medical cannabis and tell that it's working better. Clinical trials done, it works better than composine, but not better than Zofran and steroids. But as a supplementation possible, especially if it's associated with anxiety and pain. So I have a couple cases and we can go over first case. So I have 58 years old woman with metastatic cervical cancer who was treated with chemotherapy, carboplatin, paclitaxel 3 days ago. And she presented with nausea and vomiting. She's not able to take her anti-nausea medication and she's not able to drink or eat because of nausea and vomiting. So this is her CAT scan. So what do you think you should do? Start IV hydration, drain her ascites, give IV Zofran, give IV Ativan or any other benzodiazepine available or all of above. So, anyone? So, she has multiple causes to have nausea and vomiting, right? So on CT scan, you can see she has ascites, right? And ascites can be drained, and it will decrease irritation of her. It will decrease intra-abdominal pressure. She needs to be hydrated because she's not able to drink and eat for a while already. So, and she needs to be giving Zofran and Dansetron IV as well as Ativan IV. So I think this is illustration that a lot of time we can use more than one medication, and because it's more than one cause of nausea and vomiting. So careful evaluation of the patient is key to correct treatment. So next topic I would like to discuss is diarrhea. Diarrhea or frequent bowel movement. We usually call diarrhea when it's more than 4 bowel movements a day. So again, can be multiple cause, and it's crucial to establish the cause before you're treating diarrhea. So it can be related in cancer patients, it can be related to cancer itself, for example, carcinoid syndrome. So it can be treatment related, can be related to chemotherapy or immunotherapy or antibiotics, right? If it's not cancer patient. Can be caused by bacterial overgrowth because patient was treated with antibiotic for whatever infections they had. And it also can cause diarrhea, and frequently probiotic can be given with some degree of success. So diarrhea can be not cancer related, for example, Clostridium C. diff colitis, pretty common, especially for patient who hospitalized, who was treated with antibiotics. Viral gastroenteritis common. COVID can present it with diarrhea. So medication can give diarrhea as a side effect. So lactose intolerance common, and it can be inborn or it can be acquired. Frequently after chemotherapy, patient can develop acquired lactose intolerance. And in this situation, we ask them to keep food diary to understand what food is trigger diarrhea, and try to avoid product with lactose or use special supplement. So chronic pancreatitis can give diarrhea because of fat malabsorption, because of pancreatic insufficiency. So functional diarrhea, short bowel syndrome, we see this when patient has previous surgery. That can be because of bowel ischemia, can be because of cancer, adhesion, different non-necessary malignant or cancer-related causes. So if patient has short bowel, it's usually less than 1.5 meter left, they can have pretty bad diarrhea, and we have patient hydration dependent because of short bowel syndrome. So ileocecal valve syndrome, I think everyone should know about ileocecal valve syndrome. As you know, ileocecal valve located between small and large intestine. If this resected for any reason, in oncology, it's frequently right side colon cancer. It's resected as a part of a right colon. And patient has very specific type of diarrhea. The first bowel movement at morning, okay, and then they have multiple poorly controlled bowel movement, small during the day. That's because they don't have ileocecal valve to protect liquid small bowel content go to the large bowel. So can be extremely distressing for the patient because their social life ruined. Diarrhea is unpredictable, and they not feel comfortable to go outside, to go on birthday party, to go to restaurant, because it's unpredictable pattern of this diarrhea. So when I see patient with ileocecal valve syndrome, I think education is a key, and then we'll give them Imodium, educate, try to understand what food provoked this type of diarrhea, and try to avoid food. But most important to tell, you're not alone, we'll handle it. There is medication how to get this under control. So another important syndrome, at least for in oncology patients, called low anterior resection syndrome. That's happened when patients have rectal cancer and it was resected, and anastomosis kind of low, close to the sphincter. And this patient can develop a low anterior resection syndrome or LARS. It can also cause significant distress. It can cause social isolation because they have unpredictable small bowel movement and feeling that you always would like to go to the bathroom, and it's unpredictable, very distressful. Again, there is a whole education series for patient how to handle it. In this situation, majority of patients actually taking fibers rather than medication to stop diarrhea. In supplementation, with sometimes a small supplementation of Imodium. So, but if you have patient who complain after surgical procedure on diarrhea, just consider two of this, ileocecal valve syndrome and low anterior rectal resection syndrome, if it's relevant in the case. So how we manage diarrhea? Again, number one, establish the cause, can be multiple. Cancer related, treat cancer. If it's treatment related, you can use Imodium, Lamotil, Octreotide. We use a lot diluted tincture of opium. Very excellent medication, cheap, using from it's probably used for several thousand years for diarrhea. So of course you use hydration for diarrhea related to immunotherapy side effects. We sometimes use infliximab, it's TNF inhibitor. So if it's non-cancer related, if it's infection related, treat infection plus supportive care, right? Supportive care can be hydration, can be some Imodium on treat a specific infection. Chronic pancreatitis related to diarrhea, establish diagnosis of pancreatic insufficiency. It's not necessary to measure fat content in the stool. Pancreatic insufficiency can be established based on clinical diagnosis. Yes, if patient have a chronic pancreatitis with multiple calcification in the pancreas, or patient has significant weight loss, recent diagnosis of pancreatic cancer, especially in the head, yes, they have pancreatic enzyme insufficiency, and you can supplement with pancreatic enzyme. Pancreatic enzyme available. It started with, you can find Festal, you can find in Zestal. We have also several brand names, usually expensive compared to Europe, pancreatic enzymes. Even it's kind of straightforward medication. It's not monoclonal antibody. It's just basically dry pancreas of the cow. So lactose intolerance I already discussed. Avoid lactose containing product and lactase supplementation. In some country there is lactose free product or product with lactase, including ice cream. So, and functional diarrhea, short bowel syndrome, you know, you can use octreotide for management of short bowel syndrome, IV hydration, some Imodium or tincture of opium. So as I mentioned, ileocecal valve syndrome, Imodium, lamotil octreotide, and tincture of opium can be used. Those you have to titrate and depend on patient schedule. I never know if my patient needs twice tincture of opium and one Imodium. We work together and find a schedule which works for specific patient and specific patient lifestyle and time when they eat. And low anterior resection syndrome, diet, fibers, and consultation with gastroenterologists who know how to manage this. So let's talk about second case. So here I have 48 years old gentleman who is recently diagnosed pancreatic cancer, head of the pancreas, who presented to clinic with diarrhea and 10 kilo weight loss. His stool culture negative for infection. How you manage his diarrhea? So I have 5 choices here. We can give him Imodium, we can give him antibiotics, we can start pancreatic enzyme replacement, we can give opiates, and we can ask him to modify diet and decrease amount of fat in his diet. What do you think we should do?
Pancreatic enzyme.
Oh, absolutely. I agree. So, and actually we know that patients who started on pancreatic enzymes, they will start gaining weight. Not only diarrhea will improve, but they start gaining weight. This is essential part when you have pancreatic cancer patient, regardless of stage. Just assess if they have pancreatic insufficiency. Again, you don't need to measure content of the fat in stool. Patient can tell my stool is oily, or I have bloating, because it's pancreatic enzyme. It's not only lipase, but also some of the protein not able to be digested properly, and patient has a lot of bloating, discomfort, can be painful, plus they have diarrhea and weight loss. It's actually, it's simple and efficient way to help patient with pancreatic cancer. So let's talk about constipation. It's also common. It's also not it's common in any patient population, in any internal medicine, family practice, very, very common. So number one, we establish the cause, and then we will try to treat according to etiology of constipation, right? Medication can cause constipation. We know some of calcium channel blocker can cause constipation. Calcium supplementation can cause constipation. opiate can cause constipation. Any medication, choline blockers can cause constipation. So change diet, especially low fiber diet, can cause constipation. When I assess patient who complaining about constipation, I looking in his mouth and see, do they have actually good dentition? Can they chew? Because a lot of time, oh, you know, my dental prosthesis got broken and now I don't do any fruits and vegetables, right? That's how sometimes that's a cause that patients have low fiber diet because they're not able to chew normally. So in cancer patient, hypercalcemia can cause constipation, and we always look on calcium and albumin to make sure this is within normal range. So the hydration can cause constipation. Immobility, right? Immobility is common in any population, especially who has chronic or terminal illness. Immobility can cause constipation as well. So bowel obstruction, malignant, non-malignant ascites, and frequently constipation caused by many factors. Another important factor to remember, it's poor muscle tone, because to make bowel movement, you need to push, right? And there is not a lot of muscles. It is difficult for patient to push, and low muscle mass called sarcopenia or hypotonia can cause constipation. It's related to immobility or previous treatment as well. So in terms of treatment, halt unnecessary medications. A lot of time, if patients have advanced terminal illness or active cancer, I stop calcium supplementation unless it's really necessary if patient getting Zameta or they have bone metastasis. And we can modify some other medication to make sure that this medication do not contribute to constipation. Interestingly enough, that Zofran we use on Ondansetron, pretty common to prevent and treat chemotherapy-induced nausea and vomiting, can cause constipation, and prophylaxis very important, and explanation and patient education also extremely important. So if patients have not enough fiber because they're not able to chew normally, they don't have a good dentition to take fruits and vegetables, right? You can supplement with fibers, right? What's the most famous supplement with fibers for constipation treatment? It's plum, right? Chernoslив. Can be a juice, can be like puree in microwave, very helpful, patient love it, and easy to do. So correct hypercalcemia, this is another topic, how to deal with hypercalcemia, but there is a protocol how we correct hypercalcemia that can be malignant or not. So hydration is important. And so encourage patients to ambulate if possible. Sometimes after surgery, we ask patients to chew gum, because when we're chewing gum, it's by reflex, ask our intestine move better. And again, early ambulation after surgery, if constipation partially related to surgery or opiate use, can be helpful. So if ascites contribute to constipation, draining ascites is also important. So management of bowel obstruction, if possible, and a lot of time it is possible, it can be surgical or therapeutic management, depend of the cause. And constipation prevention, patient education. It's relatively easy, and I think nurses actually play a big role on this, and we potentially can avoid ER visits for constipation or calls from the patient. If nurse talk to the patient and tell, listen, you're taking pain medication, make sure that you take something for your bowel, or you drink Sienna tea, or you drink 3 ballerina tea. It's a lot of different supplements available even without prescription. I think nurses is actually our kind of force in terms of management many symptoms that can affect cancer and non-cancer patient population. So we can talk about bowel medication or laxative. Sounds it's very easy, but I always review with my oncology fellow mechanism of action and when we use a specific medication. We have several groups. We have stool softeners, for example, Colace and Docuzane. Basically, it's a medication that lowering stool surfactant tension and make bowel movement easy because of sliding ability. So second class, it's bulk forming agent or fibers. It's retaining water in the stool and makes this again easy to pass and make stool more bulky. So osmotic, pretty famous medication, right? It's magnesium, it's Miralax, and different enemas, for example, enema with normal saline. So it's basically act by osmosis law and cause water retention in the stool. Stimulants, two main stimulants, it's Senna and Bisacodil, and I believe there is more group available in Europe, but they usually increase intestinal peristalsis by stimulation of mesenteric plexus. So very, very important to understand that stimulants cannot be used if patient has bowel obstruction. So, and lubricants, oil enemas, again, acting as a stool lubrication. And another class we use sometimes, not too much, it's a peripherally acting mu-opioid receptor antagonist. Basically, as you know, we have mu receptors everywhere in our body, the different types of mu receptor, and peripheral mu receptor located in our intestine, and when patient take opiates, peripheral mu receptor would be blocked by opiates. This is mechanism of opiate-induced constipation, and we have medications that deblock actually peripheral mu receptor. Medication called naltrexone or Relistor. It specifically work for opiate-induced constipation with pretty high success rate, and within 45 minutes, about 70% of patients have bowel movement if constipation related to opiate use. And it's not reverse opiates in CNS, and pain control unchanged. So let's move to case 3. So I have a 64-year-old man with esophageal cancer who is currently treated with chemotherapy and radiation. So he has a pretty painful dysphagia and barely able to swallow. He is on morphine for this, and he presented with severe constipation. So, and how we would manage his constipation? So there is a couple options here. We can recommend him increase fiber in his diet. We can stop his opiates. We can give him Senna tablets. So we can hydrate patient. So, or we can use a suppository. Maybe more than one question correct here. Maybe you can use a combination.
Would be better Bisacodil.
Yeah, absolutely. I agree with you. Bisacodil suppository and probably hydration would be great, right? Of course, we cannot stop opiates because he has pretty painful esophagitis due to radiation. So I don't think that he can tolerate increased fiber in his diet because it's already very painful for him to swallow. And extra tablet doesn't look good because I think majority of his medication should be giving IV because it's painful to swallow. I think suppository would be a great option plus hydration. So, and this is another tool sometimes I use. It can be helpful. Again, anyone can advise to use this tool to your patient, family medicine, internal medicine, surgical specialty, medical oncology. It's called Squatty Potty. So it's a special small stool which can be used as additional help when patients have constipation that's usually related to poor pelvic floor muscles. It can be helpful to patient who has radiation to the pelvic floor. It's usually patient with gynecological malignancy. It can be young patient with cervical cancer who had high dose of radiation to the pelvis and they do not have a good pelvic muscles. Or patient who has hemorrhoid. And with this position, it's much easy actually to push stool out. And it's available, can be a self-made device, can be very, very helpful. And so just remember, and here it's available everywhere. And I have several patients who told me, listen, Dr. Olga, it changed my life. So, and it's purely mechanical, purely positional. So, and now we will move to the management of bowel obstruction. So, bowel obstruction in oncology, but I believe in surgery as well, we have 3 types of bowel obstruction. We call this GO, gastric outlet obstruction, SBO, small bowel obstruction, LBO, large bowel obstruction. Yes, we have also rectal obstruction, but we consider part of large bowel. So in terms of the management algorithm, we have to understand that 25% of patients who has bowel obstruction and who has concurrent cancer diagnosis have non-malignant cause of this obstruction. Don't think that any bowel obstruction in cancer patient have malignant bowel obstruction. So common surgical adhesion from previous surgery or radiation, ileus, severe constipation, medication. This is 25% of non-malignant causes, right? It can be intraluminal, right? Intraluminal obstruction is mean tumor sitting inside the lumen, or foreign body sitting inside the lumen, right? Extraluminal, it means something pushing, for example, big peritoneal implant pressing against your gastric outlet or small bowel. And it can be functional. Functional bowel obstruction when patient has infiltration of mesenteric plexus, and basically your mesenteric plexus is in charge of bowel function, not functional normally. And so we need to establish obstruction level. We usually do X-ray of the abdomen called KUB. So contrast study, not easy to do, but possible, right? With gastric outlet obstruction, the contrast study is impossible. Good quality CT is impossible. We usually do small bowel series, and KUB also can help us. So sometimes we need to do upper endoscopy to prove that patient have gastric outlet obstruction and prove the cause. So, and we try to palliate obstruction no matter what. Sometimes it's the cure of obstruction impossible, but management of symptoms definitely should be done. So when you manage and make a decision about obstruction palliation, you think about life expectancy, and you think about feasibility of surgical consult, and you think about gastroenterology consult. So if patient has potentially reversible surgical cause of obstruction, for example, adhesion, or you have specific points that your surgical colleagues can resect and alleviate obstruction, it can be offered. But if patients have a very life expectancy and have very short life expectancy, have extensive peritoneal canceromatosis, usually there is no role for surgical intervention. Gastroenterology consult can be helpful. Our GI colleagues can offer stent. It can be duodenal stent, it can be rectal stent or large bowel stent. Usually small bowel stents is near impossible. So if patients have a stent, they have to be on a special diet. Very important piece to make sure that stent is not dislocated and not reobstructed. So how we usually manage, as I mentioned, we need to establish cause of bowel obstruction, offer imaging. So patient should be nothing per mouth. However, patient can do sips and spit it, or patient can do ice cubes or juice cubes, because that's important for quality of life. To be very thirsty and very dry is extremely unpleasant. You can explain patient, you cannot drink, but at least you can use ice chip or some small sips. So establish cause and treat if possible. So we frequently use steroids because steroids decrease any inflammation, and it's safe when we use short term. It can be done dexamethasone IV several times a day. Pain control, if it's associated, frequently they have pain. Pain control can be done, usually parenteral opiates. So IV fluid is essential. So we do Reglan if patient metoclopramide IV if patient have partial obstruction. Usually, if it's complete obstruction, it's not needed and can cause more pain. So sometimes we use octreotide, short-acting, somatostatin analog for bowel obstruction. There is a data. It's actually hormones that decrease production of many gastrointestinal hormones and decrease swelling of GI tract. So what you don't want to use, Senna. So that's very important. Any prokinetic, any laxative that is increased bowel peristalsis, you don't want to use because it would be extremely painful and patient can perforate. So in terms of NG tube, it's always a debate between palliative care, medical oncology, and surgical folks. My policy in my hospital, no one put NG tube in my patient until palliative care or us evaluate the patient. The placement of NG tube, nasogastrial tube, is one of the most unpleasant procedures. So, and it was several studies done. It's not, it's a very difficult procedure for the patient. A lot of time, obstruction can be managed conservatively without NG tube. Now, of course, if patient has intractable nausea, vomiting, and you can see the belly is distended, the gastric outlet obstructed, and patient very uncomfortable, absolutely it can be done after we done everything. Usually after we've done everything else. So let's move to another case. A 64 years old woman with advanced ovarian cancer presented with abdominal pain, distension, nausea, constipation, diarrhea, constipation for 6 days. So how you manage her symptoms? And there is more than one correct answer. So this is her KUB. You can see fluid level. and you can see that she has obstruction, right? Her bowel is distended. So yeah, we can place NG tube. We can treat her constipation with senna. We can start steroids IV. We can give IV morphine. We can offer her bisacodyl suppository. What would you do?
We have Kloiber symptom, and woman needs surgical treatment. Would be better nasogastric tube.
Mm-hmm. So there is a couple correct answer. So I think she will benefit from surgical evaluation. She will benefit to see general surgeon or GYN oncology surgeon. We can start IV steroids on her. Short-term steroids will not interrupt your surgical healing. It will not increase risk of infection. So for pain, regardless, we should help to make pain better, right? We can give IV morphine. What we don't want to use to give her senna, right? Because it will stimulate her bowel, she will have more pain, right? We can offer her bisacodyl suppository because she's constipated. It's kind of decompressed from below. We can, if it's not efficient, we can offer her NG tube. And so, but again, it's obstruction can have multiple reasons. We don't know, in my presentation, we don't know if patients actually progressed from ovarian cancer or patient have bowel adhesion because of her previous treatment, right? It's the serial, we can treat the patient and do serial KUB, we can get surgical consult going, but while we're doing everything else. A lot of time, obstruction, if it's non-complete, if it's partial obstruction, can be resolved with therapeutic management. So, and I have reference at the end of my presentation, management of malignant bowel obstruction, and I think it's important to read to every specialty, family doctor, internal medicine specialist, and surgical specialist to make sure that they aware about different treatment options, because a surgical team gravitate to do surgical intervention and nothing else. Therapeutic team usually do more therapeutic intervention because we all have our own bias. So, and next symptoms I would like to discuss is dyspnea or shortness of breath, pretty common, right? We need to establish the cause. Cause can be pulmonary embolism, can be pneumonia, can be COVID, can be anxiety, congestive heart failure, obstruction, can be pleural effusion, cancer progression, chemo or immunotherapy, toxicity. Extremely important, right? It's common everywhere. It's not only cancer related, right? You could have patient with chronic CHF and pulmonary embolism, and suddenly shortness of breath is worse, or with pneumonia or with COVID. So anxiety frequently present as well. We in the management, we can always offer anti-anxiety medication. We always can offer oxygen. If saturation is low, sometimes for comfort, we can also offer some inhalers, broncholytics, especially if patient has COPD, chronic obstructive pulmonary diseases. So if patient has lymphogenetic spread due to cancer, it's obstruction of small lymphatic vessels, we can add steroids, but usually it's pretty bad prognosis. So as you know, opiates work very well and decrease respiratory rate, and they work actually centrally. So we can always offer morphine or hydrocodone, including standing hydrocodone, just to use for shortness of breath. Even patients do not have pain, hydrocodone can be used for shortness of breath and titrate from 10 milligram every 8 hours and up. And so I know we're running out of time. I have a couple more slides. Another case, a 72 years old gentleman with metastatic lung cancer who has prolonged history of smoking. He progressed on many treatment lines and he presented with shortness of breath, low oxygen saturation, and anxiety. So this is his imaging. This is his CT. How you manage his symptoms. We can start IV steroids, we can give Ativan, we can start hydrocodone, we can give inhaler, nebulizer, or all of above.
Any suggestions?
Maybe nebulizers, start with nebulizer therapy and inhalers.
First step is oxygenotherapy.
So, no, I agree with you, both of you. So what we see on this imaging, right? So I presume this patient do not have miliary tuberculosis or histoplasmosis, right? This guy has prolonged history, metastatic lung cancer. This is lymphogenetic spread of his lung cancer. This is pretty bad prognosis. So I would start oxygen, right? I would give him Ativan. I would give him inhalers, right? Because he has prolonged history of smoking. All people with prolonged history of smoking and lung cancer, majority of them have emphysema, COPD. They need some sort of inhalers to improve their respiratory reserve, right? So we can start hydrocodone and offer steroids, but steroids would be the main, and oxygen would be the main kind of driver to help him, but prognosis days to weeks. It's poor prognosis if we see lymphogenetic spread from any solid tumors. So anorexia, poor appetite. We need to establish cause, right? And potentially cause, it can be chemotherapy itself, medication, can be depression, I didn't mention here, can be oral ulcers, it can be oral candida, it can be dry mouth, pretty common, nausea, right? So anorexia complex require time, attention to details, frequently nutritionist consult, and that we're blessed to have cancer nutritionists who can take time and talk to the patient. We have different menus for the different ethnic background. I learned what to use for patients from China, from Vietnam, from Africa or South America, what specific diets they like if they don't have big appetite. So frequently we use Marinol. Marinol is a synthetic THC, main component of medical cannabis. So we use steroids orally. It can be 2 to 8 milligrams a day, very helpful for appetite and well-being. I have reference about randomized clinical trials, steroids in advanced cancer patient. It's safe and an improved quality of life. Don't be shy to use dexamethasone. So Megase or Megestrol, we almost not using this. It's extremely thrombogenic. It's old medication. I understand it's cheap. It's cause fluid retention. And I mentioned already Marinol, and frequently I recommend medical cannabis in edible or oil form. So safe, well tolerated, and have many action. Can treat anxiety, insomnia, nausea as well, and improve appetite. So delirium. Common in any end of life and with any advanced disease, extremely distressing to the family, right? Change of cognition, mental status change, and can be kind of subacute, can be quiet, or can be in degree of agitation. So we need to establish cause, right? Plus we have to think about life expectancy. Someone who is actively dying, right? We don't necessarily need to establish cause. We just may need to focus how to make this better. So if patient has not actively dying, reasonable life expectancy, we can check the electrolyte, two main, sodium and calcium, rule out infection frequently, urinary tract infection, check ammonia in patient who has chronic liver disease or significant liver metastasis, and treat correctable causes. Check medication. Benzo opiates can cause delirium, can cause hallucinations. Some of patients have paradoxical reaction to it. So we can add steroids if patients have brain edema, brain metastasis. Potentially, if patient has elevated ammonia, rifaximin can be added, and rifaximin medications that decrease ammonia without giving patient diarrhea. What we don't use in hospice or palliative setting, we don't give this patient lactulose, because it's horrible if patient have delirium, limited life expectancy, and running to the bathroom 4 or 5 times a day, or we're using diapers, and it's extremely uncomfortable for the patient because lactulose can cause diarrhea. And so we use Haldol or Zyprexa. It can be giving PO, including under the tongue. So for some patients, especially for elderly and hospitalized patients, melatonin decrease risk of delirium, and melatonin is available. It's a safe medication. And so family education, right? Tell patient families that it does happen, and a brain not functional properly. And I tell the patient family, please be with patient, orient patient, bring home things, right? The family can bring a home blanket, home pillow, some toys, some pictures of the family. It can be very, very, very helpful. So, and I have two last slides for symptoms you may see in the family practice or internal medicine or oncology. So one symptom is pruritus or itchiness. So can be very unpleasant and have negative impact on patient quality of life and social well-being. So very important to establish the causes, right? It can be different causes. It can be elevated bilirubin. This is straightforward. They itchy and they yellow. It can be dry skin for many reasons, and it can be neurogenic, uremic. It can be related to medication. So interesting that pruritus or itchiness, there is 5 different types. One is coming from skin. It's called pruritoreceptive pruritus. Coming from skin, we can use antihistamines. It can be used topical, and sometimes it can cause by dry skin. We can use just moisturizing. And so a neuropathic pruritus, it's can come, for example, after herpes zoster, patient can have itchiness in the area of the nerve and dermatome distribution. Neurontin or topicals can be helpful. Sometimes lidocaine patch can be helpful in this type of pruritus. So neurogenic pruritus, unusual condition, frequently associated with uremia and elevated bilirubin. It can centrally irritate centers responsible for pruritus and sensation. Small dose of SSRI can be helpful. Mirtazapine for pruritus related to cholestasis and elevated bilirubin, we use cholestyramine. So sometimes UV light can be helpful. And so, in psychogenic pruritus and associated with psychiatric disorder, and should be treated in conjointly with psychiatric disorder with SSRI, neurontin, and antipsychotics. And paraneoplastic pruritus related to cancer. Most common is lymphoma, Hodgkin's lymphoma. Steroids and treat cancer, and pruritus can resolve. So, in hiccups, so in Latin, singultus, so can be unpleasant symptoms, and you need to know how to manage. So can be extremely distressing, and every year we have admission to the hospital with intractable hiccups. So it can be acute, persistent, or intractable more than 48 hours. Management, no one knows exactly what remedy will work. More than 100 remedies and methods how to deal with hiccups exist. So non-pharmacological, we all know gargling, any vagal stimulation, any breath holding, biting the lemon can help and can resolve this. So also divide on several types. One is originate from gastrointestinal tract. It can be treated with PPI if it's related to gastritis or reflux. It can be treated with metoclopramide. So, and hiccups is actually very severe diaphragm spasm. And a lot of time we use muscle relaxant, for example, baclofen for this, and sometimes calcium channel blocker can help to relax diaphragm. Also, we use neurontin or thorazine. Sometimes we use lidocaine IV if hiccups persist and intractable. So in central hiccups, it can be related to basically vagal nerve stimulation by tumor, by trauma, by hematoma, or stroke. So we use baclofen, steroids, we use neurontin, and again, we use antipsychotics such as Haldor, thorazine. If it's really intractable, midazolam IV can be used. An interventional procedure such as vagal or phrenic nerve blocks can be, or stimulator can be used for intractable hiccups, but I believe in the literature that it was one guy who was hiccuping 28 years. So, and no one can help him. So, and I believe this is my last slide. So, and thank you so much. If any question, I'm happy to answer. And I put several references about symptoms management and palliative care. Thank you.
Thank you,
Thank
Olga.
you
Olga, I have the questions.
Mm-hmm. Yes.
What is your opinion for using of the antihistamine drug of first generation, cyproheptadine or peritol, for stimulation of the appetite, especially for normal condition of oral cavity and gastrointestinal tract?
So we actually, I think we don't have this medication. It was concerned about safety of this drug. And I know some people getting it through Europe or Canada. In US, we don't use it.
Thank you. Thank you, Olga.
So, but appetite stimulant, I think probably the most common we use now, you know, it's we use steroids and we use cannabis a lot, and again, it's so well tolerated.
Yeah. Thank you. Thank you for your lectures, for all lectures. I like your lectures. My students likes your lectures.
Oh, thank you so much.
Welcome again at next semester, Olga.
Oh, yeah, absolutely. I would be happy to come back and give you more. Okay. So, and you have my email. If any questions, if you need any reference, please let me know. Happy to answer. Okay.
Thank you very much. Thanks a lot. Really, we are very happy and we thank you. So I hope for our next lectures about medical cannabis and the use, and think about something like bad news delivery like that.
Okay. Thank you, guys. Bye-bye. See you next semester. Bye-bye.
Thank you.
It was my pleasure.